Okay, so hello everyone. Welcome. For those of you who are not from the Berman Institute, we are particularly glad to welcome you to our community and our space. Again, with apologies, I'm going to read part of my introduction because I want to make sure to share a few details about our guest speaker with you. So we have the pleasure of hosting Dr. Govind Persad today. Mr. Govind Persad. Mr. Govind Persad. Sorry.
Ellen McKenzie did the same thing. I stopped for a second.
We can't help ourselves. Everybody here is a doctor. Right? Mr. Govind Persad is currently a law clerk for the Honorable Carlos Lucero of the U.S. Court of Appeals, 10th Circuit in Denver, Colorado. He did his undergraduate degree at Stanford University, where he was Phi Beta Kappa and did a double major in biology and philosophy. He then was a pre-doctoral fellow at the NIH Department of Clinical Bioethics, where many people here have spent time, before then returning to Stanford to complete a JD from the Stanford Law School. He now is working toward completing a PhD in philosophy, also from Stanford, where his dissertation is titled Moving Toward Fairness, Normative Aspects of Social and Economic Mobility. Govind has published extensively on different topics in health policy, cost effectiveness, priority setting, the Affordable Care Act, and sufficiency in health coverage. He will speak with us today on how should we incorporate financial risk protection into universal health coverage. The one other comment I wanted to make before forgetting is that after Govind's talk, he's happy to field his own questions, but one thing that we agreed might be helpful is when you ask a question, if you could identify yourself both by name and just a sentence about who you are in this community, that might help Govind. So we're very happy you're here. Welcome.
Thanks. Yeah, thanks, Nancy, for that introduction. Now that she mentioned that I was a clerk, I feel like I have to do the thing that we always used to do at the NIH, which is to say that what I'm presenting now is my own views. It's not the position or policy of the U.S. government, I guess, or the federal courts, because it used to be the Department of Health and Human Services, but it's definitely not any position of the Department of Health and Human Services. So I'm here to talk to you today about the relationship between the concept of financial risk protection and designs for universal health coverage. And I've actually given different versions of this talk to two very different audiences so far, to folks, a lot of whom were health economists at the University of Bergen at a conference, and then to economic law panel of the American Society for International Law, and gotten really different feedback from those groups. So I'm really curious, and I'll be really grateful to see what commentary you all have today. So without further ado, I'll go right into the setting up why I think this problem is interesting and give a little bit of a roadmap of what I want to talk about today. So in health system evaluation, and particularly in a couple of documents by the WHO, a 2000 white paper on healthcare system design, and then more recent work in 2014 by some of the same group in Norway, including Ulla Norheim. These groups have taken the idea of fear financing, which includes protecting people against financial risks, major weight when evaluating healthcare systems. Despite this, there's been comparatively little work done on the normative or ethical justification for why financial risk protection matters. So a lot of the existing work has stipulated some definition of the risks against which we should protect people financially when designing systems, and then gone on to empirically investigate how well systems might be doing at protecting against those risks. But there's much less work on why we should choose one or the other of a set of candidate definitions of financial risk protection. And this is a particularly important issue in my view because there's a push toward having universal health coverage expand globally. So there's talk about having universal health coverage be one of the successor goals for the Millennium Development Goals, for instance. And to the extent that we're thinking about expanding universal coverage into areas where the financial constraints are more acute, it makes a lot of sense to really think hard about what are the financial risks we are going to use limited health system resources as we design universal health coverage to protect against. So my aim today is going to be, first, what I think is sort of the easier part is to review and offer some critiques of existing approaches that people have offered in this space. So existing definitions, some commitments that I think are not well justified. And then toward the end, I want to propose the beginnings of an outline of a new, the approach I would suggest to thinking about financial risk protection. And I think the second, the positive part, is the more challenging part than the review and critique part. But I'm hoping to get, in future work, beyond the outline and think more about how to operationalize this approach and how to lay out more specifics and how it might work. One of the families of thresholds, thresholds we think about when we're thinking about financial risk protection that's been proposed in the literature is what I'll call a social minimum threshold. And the idea of these types of thresholds, these types of approaches to risk protection, is we're protecting households from dropping below some minimum. So, and there's two species of social minimum thresholds. Often the literature doesn't distinguish between them, but some other sources, particularly in political science, some in philosophy, have distinguished between absolute minimums. So, say one financial risk we want to ensure doesn't happen to households as a result of healthcare spending is dropping below, say, $1 to $2 a day. This has been a sort of UN promulgated guideline in less developed countries. You can imagine other absolute minima. So for instance, we might think of the poverty line in the US as one species of an absolute minimum. Another way of designing a minimum is to do what I'll call a societally relative minimum. So rather than looking at an absolute minimum across societies, you look at how well somebody is doing, say, relative to the median in their society. So in the EU, I think in the UK, these types of thresholds are popular. This approach, I think, is normatively compelling. There's a lot of consensus across different ethical views, different political philosophical views, that whatever else matters, it's important to keep people from falling below some decent minimum. That's a sort of shared commitment across a bunch of different views. A challenge for this view is, when we're designing a metric, how do we think about cases where a healthcare system fails to protect people against who are already below the minimum from falling further? So do we just look at cases where somebody crosses a threshold, or do we also try to build in cases where somebody who's below a threshold falls even further? The second family that I'm interested in is what I'll call specific goods thresholds. And Jen Ruger at Penn has been one of the major folks working in this area, has done some research in Vietnam, looking at whether healthcare systems protect households against losing certain specific goods that are defined as important, normatively or ethically important, that we think it's a priority for systems to protect people against losing. So food, education, housing, these are among the candidate goods that Ruger and other people discussing these thresholds, which are less discussed, I think, in the literature than the former group, have talked about. Some of the challenges for this approach are, first, one is in whether to think of this threshold as just a threshold in terms of loss, or also one where we protect against failure to gain. So do we try to design the healthcare system, say, if we're incorporating one of these thresholds, just so it protects people against losing housing that they already enjoy? Or do we also try to design systems to try to ensure that people don't face circumstances that block them from accessing housing? Another challenge is there's maybe a lot of disagreement both between countries and within countries about which goods are valuable and how to rank them. So there might be disagreement about whether the value of home ownership, to what extent in thinking about financial risks health systems should be cognizant of. Do we care about living in a home, or do we care more about owning a home? Similarly for education, what sorts of education levels are we committed to? How do we weight different specific goods against one another? A third category of thresholds, and these are the ones that are going to draw the most fire from me in the presentation, are what in the literature get called catastrophic thresholds. So these are thresholds that look at whether a healthcare system protects a household against a catastrophic drop in year-to-year consumption. I put catastrophic in quotes because I think the argument for why it's catastrophic is sort of stipulated. It's not always well argued for. And in contrast to the social minimum thresholds, which we might think of as absolute minimum or minimum relative to your compatriots in a society, the catastrophic thresholds are in a way an individually relative minimum. So they set up the threshold based on how well you were doing before you experienced some healthcare-related cost. So the WHO has adopted in some of its documents a guideline that the drops that we should be concerned about are ones that exceed 40% of non-food annual consumption for a household. If there's a drop of 40% or more in that context, in that space, then that's the sort of thing that a healthcare system design should be concerned to prevent. Others in the literature have said, no, we should use a 10% drop, 20%, 25%, some have said 50%. So the WHO has adopted one version, but there's not really a consensus on which one is the one that we should go for. I think there's a variety of pressing normative questions about the justification for this class of thresholds. So one which I sort of alluded to is what justifies one percentage threshold over others? So what justifies setting it at 40%, saying drops of that or more, those matter morally, below that they don't matter as much. So why set that as a cutoff point? Another is what justifies describing any percentage threshold as, that is what justifies describing sort of the species of percentage thresholds is defining the kinds of outcomes against which we ought to protect households. And the worry here for me is twofold. One is that it might be unhelpful to poor households. So if you're right near a social minimum line, or you're right near the line of losing some specific good, dropping by much less than 40% might implicate an outcome that's really significant. If you're doing really well, or even decently well, you might experience a fairly substantial drop in your non-food consumption without it being necessarily right to refer to it as objectively catastrophic. It might be subjectively catastrophic to the household in terms of its consumption, but they might still be doing better than the median, maybe better than a lot of other households that we don't consider to be in dire straits. So this is a quote from Adam Wagstaff, who's a health economist who's written in this area. He worries that the catastrophic approach doesn't capture how far catastrophic pain actually cause hardship. Now, Wagstaff doesn't go on to offer an account there of what hardship is, but you might think that if one of the other two accounts gives us a better key to hardship, this approach isn't capturing the things that the other two are. So now that I've talked about these three existing thresholds that are out there in this literature, I'm going to move on to some commitments of people writing in this area that I think are popular but not well justified normatively. So the three that I want to talk about here are, just to go in order, one is this idea of what I'll call fully decoupling financing. So this is the idea that healthcare system financing, and in particular on a household scale, how much money a household pays into the healthcare system, whether through taxes, out-of-pocket payments, other types of payments, that should be entirely separate from the extent to which that household uses the health system or imposes costs on that system. So that's one commitment that I think is somewhat prominent in the literature, but I don't think is really well justified. Another that I'll talk about is the idea of maintaining status, so that we should, this I've kind of touched on in my criticism of the catastrophic thresholds, but that even when people who lose out are absolutely and comparatively well off after their loss, that it's still a high ethical priority for health systems to protect against those losses. And the third that I want to talk about is that there's also a view that we should, when we're thinking about financial risks, we should think about those risks in terms of annual income, or perhaps in terms of annual consumption, but the measure should be annual. That we should protect against these year-to-year losses, rather than thinking about how disadvantaged a household is, or an individual is over a lifetime, over a longer time trajectory. And this commitment is the case on some views, even if a lifetime disadvantage is greater, and even if it's suffered by folks who are worse off, as long as it's coming sort of drip by drip and not in a larger drop, it ends up not being captured by a lot of the existing approaches to thinking about financial risk protection. So I'll go first to the fully decoupled financing view. And this is a view that I think Chris Murray, who's been influential in developing some of these WHO documents, has promulgated in a few different forms. But one version of it, which comes pretty close to something that he's advanced in a few different articles, is the idea that the ratio of total health contribution to total non-food spending should be independent of the household's income, of the household's health status, or of the household's system use. So for instance, if a household that's earning $200,000 a year is expected to pay $20,000 into the healthcare system, so it's expected to contribute $20,000, then by this principle, a household earning, we're replaced here, this is not really important, but earning with sort of non-food spending to make it accurate. A household whose earning or non-food spending is $20,000 a year would be $2,000. So it's a linear ratio. It's analogous to a flat tax. And the trouble that I have with this morally is that it ignores a potentially relevant disparity in disposable income. So if I go from 200,000 down to 180,000, it certainly might be disruptive to some plans I have for my life, but it seems quite different morally from if I'm at 20,000 and I might be right at the edge of being able to make my rent payments, or right at the edge of being able to access food for my kids, and I drop down to 18,000. And that is a case where I think the linear ratio way of thinking about things isn't attractive. Another way that it's not attractive is that it rules out any degree of basing payment on use, even when there might be advantages in healthcare system design from connecting the extent to which a household uses the system to the amount that it pays in. So for instance, if you're really going to stick to the fully decoupling principle, you're not going to be designing a healthcare system that includes any out-of-pocket payments that are based on system use for, say, minor ailments, or co-payments for wealthier individuals in an economically stressed healthcare system. These sorts of co-payments can be useful in controlling cost. And so that's one, to the extent that controlling cost lets the healthcare system cover more interventions, reach more people, that can be a good reason to include some degree of use-based payment. Another thing that I think gets ruled out by the full decoupling view is that you're not allowed to do what I'll call into-pocket rebates rather than out-of-pocket costs for choosing cost-effective or lower-cost healthcare options. So some have proposed value-based insurance designs where if you choose a healthcare option that imposes lower costs on the system, you might get even potentially a rebate on some views, or your obligation to contribute would be reduced. And these programs violate this full decoupling picture because they financially reward system users for incurring fewer costs and so imposing fewer costs on healthcare systems. So these two species, the sort of worry about getting the targets of help wrong and then ruling out these potentially beneficial approaches, are the concerns that I have about the fully decoupling approach. Now, these slides are coming out, the text is coming out a little smaller, but I'll walk through it, is a few different justifications for the decoupling view have been offered, and these are ones that I've sort of teased out of the literature more than are made explicit in some cases. But so the thing I was wondering was, after I thought, I don't think this makes a lot of sense, I thought, well, why do other folks think this does make sense? And I came up with 4 species of justifications. So one is the idea that maybe we should decouple system use from payment into the system because healthcare costs are unforeseeable. You can't foresee that you'll incur healthcare costs. The trouble here is that to the extent this is true, it's also true for many non-health expenditures like repairs and education. And it's also not true in a sense for healthcare costs. So I may not know precisely what healthcare costs I'm going to incur over a lifetime, but I have a decent idea that I'm going to incur some costs. Similarly, I might not know what sort of repairs I'm going to need for things like transportation vehicles or for housing. I might not know what sort of education I might need if I'm paying for kids in my family, but I have some idea that I'm going to have some set of these costs. At the same time, I'm not going to be able to foresee the exact nature of the costs in any of these contexts. So it's not clear that healthcare costs are unique in a way that justifies this categorical complete separation of use from payment here, while connecting use to payment for some of these other costs. Another argument people have offered is maybe, well, all healthcare costs, they're all pure bad luck. Your choices don't go into what healthcare costs you incur. I think this is a variety of problems. So one is the idea that you have to fully decouple costs whenever there's pure bad luck is ethically controversial, and there's been reams of writing on this in philosophy, but maybe more importantly for these purposes is that it's not applicable to all, again, or only healthcare costs. So there's some healthcare costs that have something to do with choice, there's some non-healthcare costs that have a lot to do with luck. So again, as with unforeseeability, this doesn't seem like something that justifies this exceptionalism about healthcare costs. A third argument, which I think is more compelling, but doesn't sweep across the whole field of healthcare, is what I call a civic entitlement argument. So you might say, we don't charge people more if they vote than if they don't vote for using the voting machine. We don't base the funding of voting on system use. Similarly, for primary education, maybe we don't think we should charge households that have more kids or that have kids differently from the households that don't. We want to separate system use in these contexts from payment into the system. So I think there are some aspects of healthcare that are relevantly like these kinds of social programs. It might be like voting or like primary education. So you can imagine things that have a lot of positive social externalities like vaccinations, where it might make a lot of sense to treat those similarly. But I don't think all healthcare interventions that a healthcare system appropriately provides fall equally into this entitlement category, where it's not only an entitlement, but an entitlement that you shouldn't have to pay for connected to use at all. And also there are other forms of civic entitlements. For instance, we might think that people are entitled to a decent level of food or decent access to housing, but we do that by trying to ensure that people have access to some level of income, and then you try to ensure that people have the ability to purchase goods with that level of income through, say, subsidies, rather than a full decoupling mechanism. The last argument, and this is the one that maybe is the philosophically heaviest, but least developed in the literature, is so I'm trying to build here on some work of the legal philosopher Shauna Schifrin, who suggested in some other contexts that some decisions people make, including healthcare decisions, need to be made for the right reasons. And for Schifrin, the right reasons often include not thinking about the costs you're imposing on other people when you're making those decisions. You should be reflecting on the place that making those medical decisions, say to have surgery or to seek some sort of counseling, how that's going to play in your personal life and with respect to your projects, and not be thinking at that time also about the third-party effects of the health system costs that you're imposing by making certain healthcare choices. I think this is a really philosophically interesting argument, but again, it's not clear that all healthcare decisions fall within this space, or that you need to have full decoupling in order to let people decide for the right reasons. Maybe as long as people aren't at risk of having some grievously bad outcome as a result of choosing a healthcare intervention, that may well be enough for them to have the free deliberative space to make their decisions for the right as opposed to the wrong reasons. It might be that we don't need to entirely insulate them from the pressure of thinking about the third-party effects of their choices. So now I'll shift over to another one of the commitments that I want to talk about and criticize. And this is this idea of maintaining status. So the worry that I have is that this is in a realm where we have limited resources and so we have trade-offs. It's going to require sacrificing other health system goals in order to prevent or rectify expenses that still leave people above a social minimum. So you're basically potentially sacrificing the specific goods, or you're sacrificing people being above a minimum in order to keep people who are doing better from falling below where they were before. And in other areas, we don't necessarily think it's so important to maintain status. So wealthier households might be asked to pay for housing or for tertiary education, while other households are subsidized. But the wealthier households, despite these fairly substantial expenditures, still stay above a minimum. So there's a question about whether all of healthcare should be treated differently, having to spend in a given year from these other forms of. Another argument that I saw, this is developed by a team of, I think, health economists writing, is they suggest that a fair healthcare system should be minimal in how much it re-ranks people, so how much people change places relatively in terms of their economic status. So that is, it should minimize relative, not absolute, but relative health-caused social mobility. And the question for this, for me, is why is, if people aren't dropping below a minimum, if they aren't losing access to really important goods, why is health-caused re-ranking such a bad thing? Why is it worse than other ways that people might be re-ranked in society, say if their house lost value, or they had a pay cut at work, or they were healthier / got better pay at work, or their house gained value? Why is that? What's different about health-caused re-ranking? So the third thing that last one that I want to talk about in here, I want to ask a question, but I think I'll hold it for responses until I'm done with the talk, just because I know when I present to philosophers or lawyers or really anyone, you get so caught up in discussions you never get through it. But I want to put this slide up there now for people to think about, which is, which of these folks merits more concern from a fair financing standpoint? So the y-axis I put in terms of income, but it's not really important what it is. It's sort of your holdings of resources. The x-axis is time. And you're comparing somebody who's sort of doing well but stands to drop if they're not treated from someone who is going to improve, but is going to improve much more if they're treated. And I've tried to give this with specifics, but then people get caught up in the specifics of the case. But you can imagine this, for instance, if you're thinking about somebody early in their working life getting access to first-line HIV treatment versus sort of second-line HIV treatment for somebody who's further on. You could think of it with respect to a variety of other interventions, but the question, the argument that I want to offer, and that sort of motivates the proposal that I offer at the end, is that I think that the green to purple move is the one that is fair financing should aim to achieve more than the red to blue move, the blue to red move. So that it's better to get the person from the green trajectory to the purple one than to get the person who would end up on the blue trajectory to the red one. And I'll be interested to hear responses from folks in the discussion about whether people share this view, whether they think they disagree, whether they think I'm missing details that might make a more nuanced comparison here. So the problems with the measuring annual income view that I have is that I think it enshrines a sort of hyperbolic discounting or short-term focus in thinking about healthcare sort of financial risks against which the system should protect. Another is that it's going to, I think, systematically favor protecting against or treating acute illnesses over chronic illness. So if a chronic illness is just going to decrease your income profile drip by drip over a lifetime, it's not going to kick in to an annual thing, but it's going to have a big lifetime impact. So it's going to favor acute over chronic, and I think it's going to favor treatment over prevention. And I think these are objectionable commitments. Another is, and this is in one of the recent WHO documents, that universal health coverage with this financial risk protection baked in will require, they say, a degree of financial subsidy, not just from rich to poor, but from people who are young and healthy to elderly and unhealthy. And there may be some good normative reasons for this, but I think there's also reason to worry about this sort of systematic subsidy, especially if there are some young people who are at risk of developing non-severe but chronic conditions that reduce over a lifetime their profile much more. So now that I've offered this more critical picture, in the last two slides I'm going to just sketch out what I think would be a different way to go in designing universal health coverage systems in light of the goal of protecting people against some bad financial outcomes. And this would be to focus on two different kinds of financial outcomes, some of which are captured by the social minimum and by the specific goods views, but I think would leave less of a place for the catastrophic or percentage-based thresholds. So the idea would be to protect individuals as far as possible against being disadvantaged in terms of lifetime income as a result of health spending. And this would fit likely into sort of a broader system of social policy that might have similar aims. So the health system isn't going to be the only thing that's going to protect people against disadvantage, but you don't want your health system necessarily, or at least I think you would need a good argument, if you thought that your health system should work at cross purposes with something that otherwise seems like a compelling normative commitment, which is to keep people from ending up disadvantaged in terms of lifetime income. Another thing that I think the system should do is ensure a social minimum even among people who aren't going to be seriously disadvantaged when you look at their income, or I keep saying income, but you could really say consumption or resource set or welfare, even if you were a welfarist. Not sure you could say welfare, but so for instance, if somebody is a senior citizen but they're formerly wealthy, if somebody is early on in education but stands to have an improving income trajectory, I think there are still good humanitarian reasons to keep them above a social minimum, and as relevant here, ensure that because of healthcare spending, they don't fall below a social minimum. And I think the weighing of these two aims against one another to the extent they conflict can vary. So I don't take a view on how these two aims are ordered here. But I think these are two normatively compelling aims that can really get support from a variety of different ethical theories. So what would the upshots of choosing this kind of approach be? I think the one potential upshot is that you would place lower priority on treatments that have little impact on lifetime income, especially those that have little impact on the income of disadvantaged households. So for instance, if a condition occurs toward the end of working life for a household, if it primarily affects households that are more disadvantaged. So there's a real debate right now in thinking about universal health coverage in developing countries about whether to expand coverage towards some more expensive non-communicable conditions, concerns about whether that will take away funding from conditions that affect less advantaged households. I think this approach could have input into how we think about these kinds of questions. Another is, this may be more of low-hanging fruit, but where treatments have little difference in benefit, then there's going to be less reason to place high priority on giving people access, even if they prefer it, to a treatment that doesn't provide as much benefit in shielding them against these risks. Now, some of these treatments, say treatments that will help mostly more advantaged households, treatments that occur toward the end of life, maybe treatments that don't have much to do with economics at all. It's not that financial risk protection is the be-all and end-all of health system design. There might well be other reasons to put some of these treatments into a healthcare system and support access to them. But in thinking about whether the financial risk protection piece of the puzzle justifies providing those treatments, I think this prioritarian lifetime approach, prioritarian because it puts priority on people who are worse off, would give less support to those kinds of approaches. So, all right, so now I've sort of canvassed this existing literature, offered some counter arguments, and then sketched a view, and offered you that slide. So maybe I'll skip back to the slide and then leave it open for questions.
The floor is open.
Yeah, Brendan.
Hey, I really admire the work. I think this is exciting and important stuff. It strikes me that you offered us a view here that's very divorced from other kinds of forms of social protection that might also exist or not exist in a state, and that those other forms of social protection might be as important, if not more important, in making sure that there's a decent social minimum in terms of other goods. So I wonder if you had a view on whether the kind of prioritarian account that you offered us, whether the relative priorities toward financial protection or the weighting that you might have in a case like this one, either in favor or against somebody who's more advantaged and but would also get a better benefit from getting some health resource, is dependent on the kinds of forms of income protection that exist.
Great, yeah, so this is really, one of the challenges with doing any sort of applied ethics when you're working with respect to one good in society is that it can be tough to avoid either having to give a full theory of social justice for the whole society, or potentially, what I would like to be able to do ideally is be able to graft something like this onto a variety of frameworks so that this shouldn't be only endorsable by people who are utilitarians or only endorsable by people who are egalitarians or whatnot. So I take it part of the question is, say I proposed who should get more priority in this kind of case where the financial bad outcome comes about or less good outcome comes about as a result of having to pay for healthcare spending. Do I think that, for instance, we should think about mortgage insurance or about the design of food policy or other policies in the same way? So in the dissertation, I take up this question with respect to some other policies, some social insurance policies like retirement and some policies related to housing. And largely, I do think that this sort of prioritarian lifetime view would be proper also with respect to a lot of these other policies. The caveat is that I do think there might be a difference between the obligations of a public actor, like a state actor, and the obligations of private actors. So it might be that private actors have more of a responsibility to protect people against downward mobility that doesn't threaten a minimum, because maybe they've made certain kinds of commitments that sound more in a species of contractual commitment. Whereas I think to the extent that state actors have more broad justice goals that aren't, so say whether, for instance, this should be thought about when we're thinking about design for private employers' pensions, I think might be a separate question from how we should think about it when designing healthcare systems. I could imagine, though, arguments, and these would be arguments in sort of more of maybe a flavor like a scholar like Michael Walzer, who thinks that different goods are subject to different distributional requirements, where you might say, well, actually, the source of the threat to financial protection really matters, and maybe being put into a lower financial place because of certain sources is different than for others, and so maybe we should care about the blue to red change more if it's not a health context. I can imagine an argument like that, although I haven't seen it in the literature. So, thanks. Theodore? Or Ted, how do you go?
Ted's fine.
Ted, right.
Thank you very much. Kind of working with, this is the right one to have up for what I'm going to ask you. Thinking about a kind of arises with the Amartya Sen's work, when you're dealing with and I like the fact that you're pitching this to sort of at a point of overlap, or potential overlap among multiple theories. But in some, you're dealing with resources, things that are presumably of instrumental significance, which for certain theories of justice, that's where you stop. What do you do with the issue of conversion factor problem? So the kind of thing where certain individuals, when we talk about a minimum, this comes up because can you convert that minimum, or maybe whatever your income is, into valuable functionings? You know, an individual who has conversion deficits, conversion factor deficits, maybe the person who, even though they're at the red line on income, is actually below the purple line in terms of what they're able to do with that because of this conversion thing. I think it's to be a friendly challenge in the sense of, I think there's plenty of room to build it in, but I was just curious about your insights to build in pragmatic concerns about conversion order disparities, conversion factor disparities into this account.
That's great. So there's a couple of different ways that I could go with that. One way is I could say, if we assume, we sort of stipulate that there aren't conversion differences, and then treat it as defeasible. So if it turns out that that person has a conversion difference, then you might rethink the reasons that you have starting out, the sort of prima facie reasons for going this way. Another thing you might do, though, is you might either, and there are disadvantages to going each of these ways, you might say, well, if the conversion thing is right, this is really a problem for a sort of resources view, and what I need to do is cash out those numbers on the left, turn them into capability numbers, and then, or functioning numbers, and then I don't have to worry about that. The other thing I could say is, I could say, well, if we're just thinking about it at a population level, rather than being, but I'm going to say this, but then I'm going to say why I'm worried that it's not going to work. The last thing I could say is I could say, well, on average, we can think about people having this sort of ability to convert resources into outcomes. And so we don't have to worry about the details of people's individual conversion factors because you just pick the arrangement that's going to be best for sort of the average conversion factor. The problem for that I'm worried about is if it turns out that the person, the blue to red case, is actually in fact going to end up being the worst off when you take into consideration their conversion factor, then I worry that maybe we're only getting to an intermediate thing and we're not going to be getting to what we value because you're actually not helping the person who's worst off in terms of what we care about, assuming what we care about is functionings or capabilities and not just this proxy. So I guess that would be a way for going, that would be a reason for going for one of the other two approaches. I think the second one would probably be the most powerful, but it would require settling a vexed question of what the right theory of distributive justice, it's not a good word for it, but the distribuendum, the thing you're distributing, what that is. And to the extent I'm going to punt on that question, I think I face that challenge. Yes?
Well, thank you, and very interesting work and very interesting presentation as well. Could you speak a little bit more about the force of it being a lifetime approach and not merely a social minimum approach? Right? So that seems to me what you're hanging a lot on, and I want to understand better why the force of the lifetime approach, which is very popular these days. So why is it captured your view? Why not just a prioritarian approach?
Yeah, so I guess I think that the lifetime part of it hangs in some ways apart from some of the criticisms I make of the other views. So you could have a view, which isn't the one that I defend here, that says what's important is to keep people above a social minimum in each year. I think that would be probably an improvement over a lot of the current views. The thing that I find compelling about the lifetime approach, particularly when thinking about some of these problems of health system design and public health, is that I think the lifetime view gets, well, by taking a more sort of forest rather than trees perspective on a household or an individual's life, I guess, can help capture what to me seem compelling reasons for caring about treating chronic conditions in ways that if this condition in no year threatens the person dropping below the minimum, it wouldn't necessarily get at that if you just did the minimum non-lifetime approach. That is, say if the green line were never below the absolute year-by-year minimum, then you might not care about it if you weren't thinking about it in terms of lifetime disadvantage.
So what I'm trying to understand about that is, and that's important from the standpoint of financial risk protection for the person or the household, or from the standpoint of public health policy?
Oh, good.
That's what I'm trying to take apart here.
So both, I would say. So it would seem to me important both to the household or to the individual that their lifetime access to goods is, and it would also seem important, I suppose there's a question about whether the aggregate reasons we have to care about a policy are just a sort of combination in some way of all the individual reasons, or whether there's some independent reason over and above what individuals or households value to care about a society being one such that people do better. That might be an additional reason to care about it, but it seems to me that it could be compelling both from, I suppose I'm not sure how to understand when you're asking about the public health policy perspective, but well, why don't you follow up, because I feel like
I don't want to monopolize this.
No.
Just push you a little bit. So
Yeah.
the lifetime prioritarian view that you got, right? But you're also endorsing the social minimum approach. And I'm trying to figure out the added value over the social minimum approach. So if we can accept that a better approach would be one that says we're going to protect people from financial risks such that they never fall below on an annual basis, whatever social minimum. We could cash it out in terms of dollars, we could cash it out in terms of a well-being account, whatever you want, right? Now you've got this lifetime approach. So I'm a household and I'm in time one and I'm a young household or I'm an old household. I'm having trouble understanding how this is going to work from the standpoint of my own interests. Right? I get how it could affect public health policy from the standpoint of putting a bias in favor of one kind of treatment versus chronic versus acute, preventive versus treatment. I get all that. What I'm trying to understand is from the social justice standpoint, and at one point you said that you were favoring the social minimum approach for humanitarian reasons, which was another thing I wanted to push you on, rather than justice reasons.
So
So
that was,
maybe I should just leave.
no,
it
that's,
at that.
that's great. So I think maybe they sound injustice in different ways. So the social minimum, so say, I don't have a social minimum on this chart, but say the social minimum were here. So say we're at the, maybe this has a laser pointer? No.
Make it up.
Yeah, so say the social minimum were sort of below the green line. Then, if you had a pure social minimum approach, the view would have nothing to say really about this choice,
That's right.
because it wouldn't be sensitive to these further differences. Then, from the lifetime approach, the question, I guess, well, so you asked a question. Let me answer the second one first about the humanitarian thing, which is, I think,
Let other people talk. and we
these
can
are
talk about
both
it.
ethical reasons to favor one kind of health system design over another, and they're as ethical reasons, and I think not only ethical, but justice-based reasons. But the lifetime reason, you might think of as being more about the fair distribution of goods in society, whereas you might think of the social minimum reason about people not being in a state of suffering or in a state of extreme deprivation. And both of these we might think of as reasons of justice to favor a policy, but they're ones that are distinct from one another. And that's why I put but I think you were right to press me on the fact that there are some folks who think, I think Judy Thompson says things sometimes where there are some things that are humanitarian or decency reasons that aren't justice reasons. And I don't think of the minimum thing as not being a justice reason. I think of them as being of different kinds. The lifetime thing, I suppose I would just say that it does seem that a household conceiving of itself as existing over time would have reason to, you could put this in a sort of maybe Norm Daniels type way, where you're sort of imagining which of these pictures you most want to avoid ending up in as a household when you're trying to think about what sort of healthcare system you want to live under. And it seems to me that the outcome as a household, imagining yourself over your household or individual lifespan that you most want to not end up in, is the green one. You most want to, and to the extent we most want to not end up in the green one, and the alternative to the green one is the purple one, for that individual, that makes sense to treat that as the highest priority. So that's some way toward justifying the lifetime picture, or at least sketching it. But thanks, those are both great questions.
Hi, I'm Caleb Alexander. I'm in epidemiology and not a bioethicist, I'll say. But I am interested in this, and I guess I'm just wondering about the practicalities of implementation. So I don't know if that's forbidden to talk about. There's a great line at the University of Chicago, that's all well and good in practice, but what about in theory? But I guess I'm just interested in, this conversion factor, never heard of it, but I don't know how you go about measuring that at an individual level and implementing it. So so even setting that aside, can you talk a little bit about either or both what health systems are currently doing and how they're innovating with respect to this question, and how practicalities would guide or inform what are reasonable normative boundaries for the framework that you're proposing?
Great. So I guess I'm moonlight as a lawyer, so I can maybe say a little bit about the practicalities. But part of the challenge here is that to the extent I'm talking about universal health coverage designs in less developed countries, a lot of this is in its very early stages, and so there's not as much knowledge about. I think the one example that I know from the literature, I'm sure there are others, but the one that Jen Ruger talks about is about the way that Thailand, she's done studies, and I think there's been some talk about trying to build some concern about financial protection against loss of certain specific goods into the healthcare system there. In terms of practicalities, so there are a couple different sorts of practical questions that might get raised. One question which I'm sensitive to in thinking about this is there might be good reasons to adopt the approaches that I don't think are sort of normatively the best, all things considered, if they're necessary to get political buy-in for a healthcare system. So if, for instance, there are people who are important to getting legislation passed who really want to have protection against financial losses because of non-communicable diseases in some country, even if sort of reflectively this doesn't seem the most compelling ethically, there might be really good reasons to do that in practice. But it's important to keep distinct the things that we do because they're sort of necessary from the things that we do because we really think they're a good idea and we would do them even though they're not necessary. And I think we often forget about this when we're designing systems. So I think you see this in some of the other, when I've been writing about some social institutions like Social Security, I think people get attached to thinking that, well, we like it and everything about the way it is perfect. And actually, a lot of the way it is there because it had to be there to get it passed. But some of it is there because it's really, really normatively important, and some of it is there because it was a way of, for sort of realpolitik, political economy reasons, getting people to sign up. The other practicality reason, which I think you're getting at, is, so I talked in a sort of general way about this really stylized example. What are specific, maybe interventions, or what are specific trade-offs that I can imagine the approach affecting when systems are thinking about design? And so one that comes to mind that I think the WHO, the recent document talks about a little bit is, for instance, to what extent we should want to provide certain sort of high-cost interventions like organ transplantation in less developed countries as opposed to certain preventive interventions or other lower-cost interventions. And you can imagine cases where there are interventions that basically look like they're going to produce changes in profiles that parallel these. And to the extent that you know something about what interventions are typically going to do, then that, thinking about this background prioritarian consideration could play a role in choosing what basket of interventions are offered, what priority or what sort of subsidy is offered for the interventions. So that's the second piece of practicality that I can imagine coming out of it. Yeah, that's
So as you think about operationalizing your system, what are the background conditions in lesser developed countries that would make them better or worse candidates for your kind of prioritarian lifetime approach?
So it would certainly depend, and in a way I feel more hesitant, even though I think the practical upshots here are in these countries, I feel hesitant saying, you know, I'm going to go in and say how you're going to distribute your interventions. I think that's not a good idea for me to go in and also wouldn't have it. The thing that I think, so one thing that would be useful would honestly be just to know about what people's values are in different countries. Do they look more like what I've argued for? Do they look really different than what I've argued for? That would be something that would be practically useful to know. Another would be, maybe, and this comes back to the question about practicality, maybe if there are some places where it would be, you have enough infrastructure to be able to look at the effects of offering or not offering different interventions, and others where you really don't have the evidence base to be able to say much about interventions. In one of those places, any sort of proposal like this is going to be much less effectively action guiding because we don't really have data to go on. In other places, there's going to be more. The flip side is that I think it's harder to, both for practical reasons and maybe, although I'm more skeptical about it for moral reasons, it's harder to take away interventions that are already being offered than to decline to offer new interventions that are just coming online. So I think whether in less developed countries or potentially in the US with respect to new technologies, these are settings where thinking about different distributive approaches might be more fruitful than saying, well, we're going to remake Medicare reimbursements or something where the status quo inertia is going to be much higher. Is that helpful? Because I feel like I've given a few different criteria that would be relevant, but I don't know that I've given an exhaustive answer.
I think we're bumping up against time.
Well, we've got 4 minutes, go ahead.
So that does go part of the way towards the practicalities, I think, of what you would need. But I'm also wondering about the background social justice scenario in a lot of these countries are very different even from each other. And so there might be some that are more amenable to the kind of proposal that you're making than others. And so I'm wondering how you might think through those background social justice issues.
trying to imagine what would be a background social justice consideration that would vitiate
That's
thinking
what I'm
about
wondering.
things in this kind of way. Can you imagine one being, again, sort of falling back on some very old stuff of people like Daniels or Marcia Angel, I think, is say that the healthcare system was super leaky, and so if you took away, or you didn't offer some interventions, you didn't think it would help in offering other interventions. That might be a reason to then doubt whether you can really make trade-offs. So if you were in a state of real, another might be if there's a lot of uncertainty about the future, that might be a case where maybe thinking in a lifetime way is less compelling, but I haven't thought as much about what background social conditions would really altogether vitiate it. I don't know that many strike me as entirely vitiating it, but maybe some would weaken the compelling a little bit. Yeah, in the back.
Hello, I'm Eric Ford, and I teach health policy and management insurance and kind of stuff. It sounds to me a lot of the prioritization, to your point, it sounds like the original Oregon experiment where they put the Medicaid program on the league table, and as I recall, the #1 most cost beneficial procedure was fixing ingrown toenails because they keep you from working, but they're cheap to fix. So the social benefit all the way around is, and that fell apart, as you've indicated, for political reasons by and large. But I guess my question is one person's prioritizations, another person's access. And you mentioned this in abstract terms, but what level of care are we willing to access? I mean, where do you draw that line?
So I don't imagine so I think the question about, for instance, think about how to frame it. So I don't think that financial risk protection is the only principle here. So for instance, say we have some other principle. I have ethical doubts about how strong this principle should be, especially when designing a system as opposed to being a physician. But say that we want to have some role for something like the rule of rescue, where you want to protect people against a big loss. I think that stands at odds with some of the things I say here, but you can imagine a system that's a plural system that is, and I think all of this, WHO and other proposals don't say, we have one principle, healthcare systems just protect against financial risk, that's all they do. So you can have other principles that you care about. For instance, you could have distributive principles that are concerned about if there's population heterogeneity where there are some groups that are socially marginalized. You could have principles that are concerned about first responders. But, so I'm imagining this prioritarian lifetime approach to financial risk protection as potentially being one part of many more principles that health system designers would consider when thinking about how to, say, roll out universal health coverage. But I do see the tension, because I could see how, say, the blue-red case feels in some ways more like a rule of rescue case than the green to purple case.
Okay, we'll end, exactly 5:30. We will end exactly on time. Thank you, Govind.